Hello all, this is Renee. I'm going to start you off on your first lecture of the semester. The title is Health Assessment. However, we will do a little of work at the end on SBAR, Sterile Field, and the chain of infection. But first we're going to do a little refresher on assessment, and we're going to add a few extra nuances to it to help you get ready for this semester. What is the purpose of a health assessment? A health assessment is the bottom line is to establish a base for your nursing process, right? So it's part of the process, and if you don't have the A in assessment done, it's really hard to go through the nursing process, right? Some of the details that you're going to get out of this: you're going to gather data about the patient's general health status. You're going to identify patient strengths and barriers. You can identify actual and potential health problems as you move through your assessment. This will also help you to create your care plan, your nursing diagnoses, and it also helps you establish that nurse-patient relationship. Believe it or not, this is your initial assessment will be your first entry into this patient's world, into their space, and it's kind of intimate doing a health assessment. You're very close, you're touching, you're asking questions and interacting with each other. Assessment, if that goes well, that kind of helps your relationship go well. So as you're moving through the assessment, talking, asking questions, gathering data in a thoughtful, mindful, comfortable way helps pave the way to a good patient-nurse relationship. Types of health assessments. So there's four main types. You have the comprehensive, the ongoing, the focus, and the emergency. We'll talk a little bit about each. The comprehensive is conducted upon admission to a healthcare facility. So in general, it's everything, correct, right? But it's going to be different depending on what your environment is. So the comprehensive physical assessment and health history gathering and whatnot is going to be very different in a clinic environment than in a inpatient environment, than in an ED environment. So when you move into the hospital setting, you're going to see what that looks like. And typically that initial assessment near the beginning of your shift is considered a comprehensive assessment. So as you get to have that experience, that'll be very different, because if it's an established inpatient that's been there for a while, that comprehensive assessment will be very different than the patient that comes in as a new admit. So more to come on that as you move through your clinicals this year. Ongoing partial. So that's something that's conducted at regular intervals. So that might be your Q4-hour vital signs, blood sugars, AC, lots of different things that you do on a regular interval. And on top of that ongoing partial, you may also piggyback onto that focused assessment. And that focused assessment might be the assessment that is focused on the reason why they're there, right? So if they're here for pneumonia, they've been admitted for pneumonia, I'd be assessing those lungs very frequently, right? So when I go in and do the vitals, I'm going to do a quick cursory listen of the lungs, or I'm going to look at them to see how their respiratory effort is, and do I need to investigate further. In my initial assessment, when I walked in the door, I made sure that they didn't have any skin lesions and that they were going to the bathroom okay. So I don't really need to focus on that. I really need to focus on what's going on with their lungs. Another important ongoing partial assessment that I forgot to mention is assessing the IV site. So you are required to assess an IV site every 1 hour at the bare minimum. So that is something that's done on a regular intervals. Same with assessing any kind of lines or drains, whatnot. Those should be done on a regular basis as well. And then the emergency assessment. Again, we're here the kind of assessment you do in an emergency situation is you are trying to determine if there is a life-threatening situation. So you're going to focus on the things that they need to maintain life. Respiratory effort, respiratory compromise, circulatory compromise. Are we bleeding out? Things like that. Anything where something unstable has happened and you need to conduct a quick but thorough emergency assessment. What makes up a health assessment? What are the components of a health assessment? Lots of different things. Health history, risk for depression, functional ability. Can they function? And that can be as easy as getting themselves up to go to the bathroom, or are they having problems navigating at home? Just getting up and moving around. Are they safe at home? And that level of safety not only extends to physical safety and nutrition, maybe nutritional safety, but it also has to do with the safety of where do they live? Who do they live with? It could be involved in intimate partner violence as well. So are they feeling safe with the folks that they're with? So all of those things need to be assessed. Of course, the physical examination, and also this is where you can start working on your patient's education and counseling as you move through the physical health assessment. Again, establishing a relationship and starting to say, hey, I noticed this has changed for you. Your blood sugar was really high this time. What'd you eat last? And, oh, you're a new diabetic. Just a reminder, you probably shouldn't be eating candy right before during the day, randomly, whatever. So again, as you're moving through, this is a great opportunity for this education and this counseling as well. Considerations when we perform a health assessment. So we have lots of different people coming to see us, and they all deserve respect and dignity, and to be treated as valuable human people. So, real important to think about who they are, where they're coming from, how they present. Lifespan considerations are real important. So, the assessment that you're going to do on a 4-year-old is going to be very different than the assessment you're going to do on a 65-year-old. With the 4-year-old might be more playful and using very basic terminology. And vice versa with the older adult, you're going to be a little more respectful and give them a chance to answer and contribute to the situation. So it also depends on what you're going to look for too, right? You're not necessarily you need to just kind of consider where people are in their lifespan. Cultural considerations and sensitivity. Again, we meet a lot of different people from a lot of walks of life, and we cannot assume because of the way they present to us, whether it's about their dress or whether they're wearing makeup or how they style their hair or what kind of clothing that they're wearing, doesn't always represent them, or it may only represent them in that moment, right? So we have to be sensitive and ask the right questions, or don't ask the right questions. So we'll talk a little bit more of that as we go through. But keeping cultural considerations and sensitivity in place. Also, real important to assess health literacy. We cannot make assumptions on how people present, whether they're literate or not, health literacy wise. So that's different than literacy, general literacy, like whether they can read or not. Some folks really have trouble navigating their health literacy as well. So something to think about. Preparing your patient. You want to make sure your patient's comfortable. So you need to make sure that you are setting yourself up for success to get this assessment completed, but also so that they can feel like they're in a comforting and welcoming environment. And let them know what you're doing, right? That's a key part of preparation. And environmental preparations. Remember that we need to honor HIPAA, we need to honor patient privacy expectations. If they come in the room and they have a significant other with them or someone else in the room with them, before you start your assessment, before you start asking questions, you need to ask the permission of the patient. Is it okay for this person to be in the room? Because I may ask some sensitive questions. Is this okay? Or would you like me to ask them to leave? Right? Super important. Factors to assess during a health history. Biographical data, reason for seeking health care, history of present illness, past health history if it's pertinent, any family history if it's important, functional health, are they able to get up and down stairs, but they live in in a 2-story flat? Is that a problem? Can they feed themselves? Psychosocial and lifestyle factors, including gender identity and how that may impact health disparity. And then, of course, a review of their system. How do you prepare a patient for a physical assessment? Consider the physiological and psychological needs of the patient. You don't want to assess somebody's bladder if you haven't let them go to the bathroom first, right? So if you know you're going to be palpating a bladder, you might want to ask them to go to the bathroom first, because that would be very uncomfortable. You need to psychological needs of the patient. If they look fearful, assess the situation. Ask them what's going on and how can I make you feel more comfortable and better about the situation. You want to explain about how you're going to do the assessment, so they know, explain the process. This is what we're going to do. Now we're going to do this. Now we're going to do that, so they can be prepared and ready. Most physical assessments are not painful, but they can be emotionally painful. So we want to be mindful and make sure that we're doing all we can to decrease patient fear and anxiety. You want to explain each procedure in detail as it's conducted, and you want to answer patient questions directly and honestly. Do not ever BS the patient, because you will destroy their trust so quickly. They will figure it out that you've told them some BS. So do not do that. Be very direct and honest, and if you don't know the answer, hang on, I don't know that answer, but I will go ask my nurse. I will go ask the provider. I will find out that information for you. Okay? Real important to be as honest and direct as possible. Preparing the environment for the physical assessment. So agree on a time for the assessment. So in the case of the inpatient world, when you are coming on, you're going to get a report. You're going to hear, oh, this one's going to PT at 9. This one has family members coming at 10, blah, blah, blah. I've got meds that are due here. I've got meds due there. I've got to get somebody here, there, the other thing. You need to synthesize all that information together and figure out when you're going to get your initial assessments done. When is the best time? You try not to interview. You try not to ask them to have a whole assessment right after they get their breakfast. It's not really helpful. Then the food gets cold. Pretty unhappy. If there are certain routines, like I said, going to PT or whatever. Visiting hours. If you can work around visiting hours, it's the most ideal, because maybe the visitor can only be there that first half-hour visiting hours, right? So if you can work around family members that are there, do everything you can possible. Now, if it's an emergent situation or you absolutely have to get done what needs to be done because there is a priority here, and it will make a difference. Like, you can't delay somebody's blood sugar check just because they don't want you to do it then. They want to do it later. No, I have to do it now because this will depend on how we treat you after that. So, so try to be as accommodating as you can, but also you have to be able to be firm enough to say, no, this I really do need to get done. You want to make sure they're as free of pain as possible. So if you walk in and they're in a lot of pain, you're really going to be better off if you medicate them first, do a quick focused assessment, a partial assessment, and they give them some pain medicine, and then you'll probably have a much more cooperative patient if you need to do a comprehensive assessment at that point. You want to make sure you have all your supplies and instruments that you need. Don't be running in and out of the room, and making sure that you provide privacy. If they're in a shared space, making sure you've pulled curtains, speak with a softer voice, shut the room door, because invariably as soon as you've pulled back the blankets to assess their bladder, housekeeping will walk right in if you don't have the door shut. At least they'll knock first and you can tell them not to come around the curtain. Gender inclusive communication. So a little nuance we'd like to add that isn't always touched upon in basic assessment is how to make your patients feel comfortable when they are not gender non-conforming and or gender variant. So just for some contextual information, patients experience healthcare settings as heterosexual spaces and oftentimes feel unwelcome. And then gender nonconforming people face significant health disparities related to discrimination. So if you're uncomfortable coming to the doctor, you're not going to get seen like you need to, and you're going to miss regular health checks that need to be done. You're going to, or someone who's not sensitive to the situation, will not present with information that a provider or a nurse needs to know because they're afraid that you're judging. So it's real important. Significant health disparities that are related to discrimination include higher incidences in using substances such as tobacco, alcohol, and drugs, tend to have higher rates of anxiety and depression, higher rates of suicide ideation and attempts at suicide. So if you feel that people are discriminating against you, there must be something wrong, can put you into this really not great mental health place. So real important to allow for a more comfortable, inclusive space. You can ask folks what their preferred name is or their preferred pronouns. I usually start out by introducing myself and giving my preferred pronouns. By offering my preferred pronouns first, it's kind of a signal or yeah, it's kind of a signal that says, hey, I'm here to support you and I'm welcome of you. And if you have preferred pronouns you'd like to express to me, then here's an opportunity. You can also ask, do you have a preferred name or preferred pronouns? But introducing yourself first and then your pronouns does open that door a little easier. So stuff to think about. On your first meeting with anyone, any patient, not just whether you know whether this person is gender variant or not. You never want to assume gender or sexual orientation by their clothing, their appearance, or by the people they have with them. So just assume everybody's just friends. I don't assume it's a wife or a husband. Ask about them being a partner or a significant other. If they don't offer their pronouns, you can always use they, them, and their as a substitute until you get to know them and you know their pronouns. And one of the things you can do is as you listen to their communication with the person who might be in the room with them or how they answer questions will give you a better insight on how they refer to maybe their significant other or partner or about their pronouns. You may hear more. You want to try to address folks in general neutral language. Don't say sir or ma'am. I was raised that way and I still do it today, and I'm trying really hard to get that out of my vocabulary. I even do it with my students. So if I do that and it's offensive, I'm really sorry about that. I'm working really hard on that. So again, listen to patients use terms they use for gender identity and relationships. You never want to ask somebody about their gender reassignment surgery or the details of their genitalia unless it has to do with the care that you are going to be providing. You just don't want to ask intrusive questions. Really important. Where it is important is, let's say a patient comes in, male appearing, happens to be a trans man, but male appearing, and they have a broken leg, they need to go to surgery. It's going to be real important to assess whether that patient has a uterus because you're going to have to do a pregnancy test before they have anesthesia. So, and they may still have their uterus. They may have all their internal organs intact. So this is important to know about what's going on in their body. But if they came for, an ear infection, it will not matter whether they have a uterus or not. It will not make any difference. So don't go there. If you use the wrong term when referring to gender, you can apologize and just say, hey, I will do a better job. Just remember also that they may not have revealed their status to anyone, including the person they come into your environment with. So just be sensitive, think HIPAA, and don't out anybody. You can always ask them later when they're alone, who knows, who doesn't know, and be sensitive to that situation. What kind of equipment are you use during a physical exam? A thermometer, a sphygmomanometer, which is your blood pressure cuff. You might need a scale, flashlight, or a pen light. You might need a stethoscope. More likely, probably the things you're going to need the most are the stethoscope, the thermometer. You might need a tape measure. When I'm a neonatal nurse and we check head circumference, so we need a tape measure for that. Risk factors to consider when you're assessing for altered health in their health history. Do they have a history of trauma? Do they have a history of pain or swelling? Do they exercise? Just a short list of things to look for or to pay attention to that might reflect on why they're here with you. General survey. So when you get started, you're just going to do a general survey. So first you identify yourself and your role, and then you observe the patient's general appearance. And this is probably your biggest, most important assessment tool. When you walk in a room, don't be looking at your phone, don't be looking at your clipboard, don't be looking at your watch. Walk right in the room. Knock, knock, knock. Hi, it's Renee. I'm your nurse for today. You need to be looking at the patient, the family, the room, the environment, just trying to get a pulse on what's been going on in the room before you come in. Real important. You will see people who are guarding, you might hear things, you might see things, anything that might give you a clue to everyone's status in the room. It's so important. Before you start touching anybody, general appearance is very essential. Next, you move to your vital signs. Almost everyone does their vital signs first. And then you might do height and weight and BMI calculation, but more likely, number one, BMI is done on Epic for you. Height and weight may not be important. A lot of times we will just ask. It'll be important for like cardiac patients. It'll be important at a clinic setting. They always check your height and weight. Excuse me. So, but in an inpatient setting, that's probably the last thing one of the last things you probably will not be checked because it gets checked on admission. And unless they've asked for daily weights, you're not going to do that. What are some of the techniques that you're going to use during physical assessment? Inspection, palpation, percussion, auscultation. Super important. Just remember when you're auscultating, especially the GI tract, you always want to auscultate first before you palpate. Okay? I just tend to auscultate whatever I need to listen to first before I palpate anything. That's just me. It's a good rule of thumb. But these are some of the words that you can use to describe those physical assessment techniques. Again, just kind of laying it out there for you, your tools of physical assessment. Physical assessment, again, it's a collection of system examinations, and you're going to do it in different orders depending on, and have different emphases depending on why your patient is there, what department or unit you work in. You know, you're going to check their skin and their head and their neck and just kind of do a cursory assessment maybe of the head and neck, but you're not going to do a big one if you're working in labor and delivery. Okay, so you're going to look at them, but you're not going to be feeling their head and checking their neck necessarily. However, you're going to really be focused on her abdomen, right? Because you're going to put a monitor on and you might be measuring and you want to see if there's contractions going on. So those things are important, right? So there's going to be, you're going to do a general cursory assessment, but then depending on where you are and what the situation is, then you will open up and do bigger assessments on those areas. Again, ways that we describe the characteristics of sound. How do we describe pitch, loudness, quality, duration? Again, words that you can use for your assessment. Again, characteristics of masses when you are palpating something. Those are some words that you'll see, or some considerations you want to mention. Size, real important to measure. This is where you might need your measuring tape. Don't guess. Measure. Very important. Good to know. Abdominal quadrants and underlying organs. Again, real important to kind of fun to know where's what in each quadrant. Just a mention on some of the different variations in the older adult. You know, you may have a difficult time palpating pulses and finding distal arteries, especially if you're doing pedal pulses. They might have varicose veins, lots of spider veins, easily bruised. They might have an increased blood pressure, and their pulse pressure tends to be a little on the wider side. And then in the lung respiratory area, they'll have an increased chest diameter usually, and that's because things don't work so well. Lungs aren't compliant, they get a little stiff, and so the accessory muscles start to work to pull the chest into what we call a barrel shape. so that there's more room to move. You might have some kyphosis. That's when the dorsal spine curves and they're humped over. Decreased thoracic expansion and using accessory muscles to exhale. So you might see somebody using their nares to flare them open to increase surface area of getting air in and out. Common abdominal variations in older adults. Decreased bowel sounds, decreased tone. We get a little chunky as we get older sometimes. Assessing level of awareness. Again, this will be whether it's appropriate or not, right? Is this a neurological patient? Is this somebody who had a head injury? Is this an older adult who might have gotten confused? Probably not going to ask this of a 4-year-old who came in because they fell down and they hurt their arm. So time, place, and person. Again, these are the 3 key big questions, things that we want to assess, and some of the sample questions. Why do we document? We document our assessments so that everyone knows what's going on, right? You're basically telling your patient's story while they're here with you. So it's real important to get that in there. Number one, once you start documenting, you'll be able to see what other folks have documented, and you can kind of start to put a picture together. You can start to see trending. It helps you to develop your nursing diagnoses. It helps you to plan the appropriate care, whether it's for the day or for the next hour or the next 2 hours. You can identify a potential problem or an actual problem that's happening right then and there. And also it's to help us evaluate patients' responses to treatment. One of the biggest areas that we struggle in as nurses is pain assessments, frequent pain assessments. So pain is your 5th vital sign, so you should always assess it at least whenever you've done vital signs, but you also need to assess it after you've tried to treat it or done something to treat it. So let's say they have a pain score of 6 and it says in their chart that if they have pain score of 6, you've got to give them 2 Tylenol. You need to go back within 60 minutes to assess them and see how they're feeling. Did it work? Is it working? Are they feeling better? Are they feeling worse and they need something stronger? That needs to be assessed, but it also needs to be charted, because if it's not charted, it wasn't done. So real important consideration that if you end up giving pain medicine, you need to go back and reassess, and that needs to be documented. Okay, so moving on to the chain of infection. Just a quick reminder, if you haven't already been reminded enough in the last 4 months about the chain of infection, just a reminder, there are 6 aspects to that. You start with your infectious agent, then it goes into a reservoir, then there's a way to get out from the reservoir. How do we get out? What's our means of transmission? We have ports of entry. How does it get in? And then who's your susceptible host, right? And you've entered into the susceptible host, and now they are housing this infectious agent. So it goes around and around and around. So what you need to understand is that we as nurses are one of the most important agents in breaking that chain of infection. We support all of these things. We are the key element in every chain break. So it's real important for you to understand why you have such an impact on your patients, is that all of these examples of how to break the chain all can apply to nurses. Hand hygiene is in all of them, right? Making sure dressings are dry and intact and they're not sopping with stuff. Making sure that we dispose needles and sharps, and we're using appropriate protective gear, and we're using sterile gloves the way we need to. We make sure our patients get their immunizations. We're screening their health care. We're making sure they get their antibiotics on time, not too soon, not too many, just the right amount and the right amount of time. Okay, so all of these places is where we can make a difference. Sterile Field, just going to go over Sterile Field really quick. I know you guys went over applying sterile gloves in semester 1. So now we're going to progress to working on sterile fields. So we'll give you an opportunity to work on that. A couple of things to think about when you're setting up a sterile field. First of all, you need to prepare a surface with Santa wipes. It's a 2-minute wet time. That means the surface has to be wet enough that it takes 2 minutes for it to dry minimum. And the way why that's important is Santa wipes work with the friction that you provide by wiping down, but also the chemicals are desiccants. So when you wipe down the surface, you are breaking down the protective cell walls of the microorganism or the pathogen, and then the chemical is getting in, and then it works to dry out the inside of the microbe or the pathogen. So we need to allow that wet time to happen so that the drying happens. If you put down supplies before that's completely dry, you've basically defeated the purpose and you've just put your supplies down on still what's considered a contaminated surface. So please follow that. Sterile drape and towels. We try not to touch them as much as possible. However, you are allowed a 1-inch border all the way around the outside that you may touch. Once you move in from that 1 inch, you are sterile and you will contaminate that area. So do not move in. Do yourself a favor and find out what 1 inch is. Some of us feel 1 inch is very tiny and some of us feel 1 inch is very big. So measure 1 inch and kind of get a good idea of what that looks like. You want to drop in your supplies, not too close, not too high up. If they're up too high, they'll flutter and probably miss the target of the field. If you're too close, you're more likely to brush your knuckles on the field. So think of yourself, if I can give you a good visual, think of yourself as a T-Rex, okay? So you're this big T-Rex body with these little tiny little hands that can't go too far, okay? So think T-Rex. You want to make sure that you can't drop your hands below your waist because that means that your gloves aren't clean anymore. You need to keep them in front of you at all times, and you try not to be on top of the sterile field if you can help it. So, so just dropping your supplies in right at that site where your little T-Rex hands are is perfect. Careful application of correctly sized sterile gloves. You're going to find out really quickly what size you are and what size you are not. If they don't have your size, you can go a half size smaller and work with those. Never go a half size up or higher. The problem with that is that your fingers will be too short and then you will have these little flippy bits at the end of your hand that don't have fingers in them. And those are the bits that are going to end up brushing on something and you will never know that you've contaminated a surface. So you need them to either be right size or just a little too tight. Like I said, gloved hands below the waist are considered contaminated. And I see that there's a typo there. It should be W-A-I-S-T, not waste like garbage. Oh, that's the other thing. Don't lean over to the garbage can to throw stuff away, okay? People do it all the time. Just drop from your little T-Rex hand position. Always acknowledge break-in technique. It happens to everyone. So always acknowledge it. You break technique. Oh, I broke technique. Start over. And you don't necessarily need to start over necessarily. Well, you might need to. Depends on how bad the break is, right? But you need to stop, change your gloves, get your situation corrected before you move forward. This is where you are breaking that chain of infection by stopping everything and fixing your break-in technique. As a matter of fact, when you guys do your videos later on, if you break technique and you don't realize it, you don't call it out, you'll flunk your video. So really serious. This is real serious. You never want to reach over a sterile field, go around it. And if you're ever unsure if there was a break or not, just consider the item or the field contaminated and just start over. And last but not least, we're going to talk a little bit about SBAR communication. So SBAR communication, it's a framework of communication between members of the healthcare team about patient condition, usually. Real important. We are going to, I know you talked a little bit about in the first semester, we're going to reinforce it this semester by having you create an SBAR communication for every VSIM that you do this semester. So you can get that practice. And our SBAR communication that we are going to be asking you to do is going to be you are giving report to an oncoming nurse. So a colleague is coming to take that patient over from you, and you need to give an SBAR report to her so she can have a successful start to her day. So that's the premise. Remember that SBAR, situation, background, assessment, and recommendation. These are general definitions. Let me move to the next slide. Explain that there's an SBAR for any situation. So even though those are the basic questions that you're going to ask or you're going to try to answer, what you're asking for or what you're saying is going to be different if you're giving this report to a provider versus you're giving it to a nurse, or sometimes in the different department that you work in, questions that you need to answer will be very different in the ED versus OBGYN care versus neonatal care versus outpatient care. So even though situations like what's going on with the patient right now, background is, what's the background, what's the history, assessment is, what are you seeing right now, what am I most concerned about, and then your recommendations, what do you need? To a provider, more than likely your SBAR is because you need something from him, whether it's orders or for him to come, him or her to come in, to see this patient. Real important, very different, that recommendation than when you're asking a colleague nurse, hey, my recommendation is to improve their taking their medications. They like them crushed up and stuck in applesauce. It's a very different recommendation than, doctor, I need you to come in and see your patient, right? So, and again, same with neonatal care or L&D, here's a labor and delivery patient. My recommendation is that you, work with her on, she's having a hard time breathing and breathing through the contractions. So maybe if you go in there and just kind of be with her and support her, and her partner doesn't know what he's doing, so kind of maybe go in there and help him learn how he can support her breathing technique. That could be a recommendation, right? So just know that SBAR can be for any situation, and it's tailored to your needs. Okay.